Everyone, thank you very much indeed for having us along to speak to you. My name is John Smith and I'm an anaesthetic at ST7, and this year for my sins I'm also the ICU Clinical Fellow. It's a pleasure to speak to you today, and we're going to hopefully have a fairly brisk, entertaining, informative and I hope challenging hour's worth of material for you, looking at a few aspects of intensive care. I think it's really important that we engage with this meeting and come and speak to you because to anyone who's ever been in intensive care, if you're not familiar with the environment, it's a little bit daunting, if we're honest. You walk into this place where there's people lying in beds with tubes in every orifice, and indeed some that shouldn't be there. The people down there talk a funny language that seems to revolve around three-letter acronyms that make no sense to anyone who doesn't work there, and it's all a little bit mysterious. I think it's really important that we engage with you about intensive care because you guys in the hospital are the source of our patients and will look after the patients that we send back to you afterwards. So it's really, really important we have some understanding about what goes on down there and the ways in which we need to interface with you. Now, there's a lot that we could have chosen to speak about here, but I thought it would be helpful to start with a few things we will not be covering today. We are not going to be covering highly technical respiratory care pulmonology in the intensive care unit because, frankly, I don't understand it either. We're not going to be talking about the madnesses that people wearing their underpants on the outside of their trousers are getting up to in trying to get people started on increasingly improbable therapies, including this gentleman who's on ECMO, I'm told, in the back of a military transport plane being transported. We're not here to throw mud at anyone. A lot of the cases you're about to hear about are based on real people, and this is about trying to learn from those cases, and it's for our learning and hopefully for yours as well. So please, if you recognise yourself in any of these cases, don't feel offended. This is not about pointing a finger. And unfortunately, we're not going to be talking about the importance of a regular caffeine intake in intensive care doctors, though clearly there's a lot of evidence for its beneficial effect. What we are going to talk about is in three parts. I'm going to introduce you in a second to Katie, who's one of our ST4s, who's going to talk about a young man with a very sore throat. Then we're going to get you to do some work and help us play the game of should they stay or should they go. And finally, I'm going to take up a little bit of the story about people when they finished in ICU and whether or not simply surviving it, is that enough for them? So if you'll let me tab between presentations, Katie, all yours.
Thank you. Thanks, John. So we're first going to look at a case that was very recently in our intensive care unit and has thrown up something that was of a slight diagnostic mystery. I'm afraid I have referenced Dr. Greg House because obviously that's where we go to and we don't know what's going on. So, our story. So, July this year, 28-year-old male had come in on a Friday evening. He got admitted through A&E and was quickly escalated to the medical high dependency unit. So he had a 5-day history of having just general sore throat. On the Monday, had gone to the GP and predictably was given advice, likely viral sore throat infection, go home, no antibiotic therapies. During the week, had also complained of worsening neck stiffness. Now, the background to this gentleman is that he had been, he's a Bulgarian worker, farm worker, who'd been in the UK for only 3 weeks. So there definitely is a potential for language and communication barriers that potentially delayed him presenting to hospital care. Other symptoms on admission that were documented: pleuritic chest pain, he had hemoptysis, dysopnea and a fever. Apparently he'd had a pneumonia 4 years ago. We didn't know this at the time until we got further information from his mother. But otherwise, this was like a young, fit, healthy, very physically active young guy. The only other thing that he'd come over to pick broccoli. There was a sort of, what bacterial infection can you get from broccoli? It was actually a total red herring, but it got us thinking briefly. So when he first came in through A&E, his SATs were 95%, breathing on 1 litre, he had a bit of a distended tummy, big liver, and as you can see there, we were sort of thinking, is this an atypical pneumonia, atypical meningitis? But it was the rapid deterioration that became apparent, and that's how he ended up with us. So 7 o'clock at night on the Saturday evening, so he'd been in hospital for 24 hours by this point. He had a partial pressure of oxygen of 8, which actually that's a good one. He also had one of 6 on 100%, hugely tachypneic, literally holding on by his sympathetic nervous system. So he was a type 1 respiratory failure that came down to us and was intubated in the unit from the high dependency. Quite quickly escalated with regards to sort of septic shock, needing high noradrenaline requirements, and we had to put him on a ventilatory setting called APRV. So when people have a primary hypoxia because of respiratory disease, it's often what gets us out of problems. So at this point, we kind of had done a lot of head scratching. For us, the first 24 hours of most admissions, like it was literally, we needed to provide intubation and ventilation to support his respiratory system. We were supporting his cardiovascular system with vasopressors and fluids. He was getting antimicrobial therapy, broad spectrum, for what was still suspected as a severe but atypical pneumonia. What other information did we have? We knew he had high white cell count, a very high CRP. We used this measure of a procalcitonin, which was incredibly high in him. He had deranged clotting and slightly abnormal liver function tests, but we were still none the wiser. So initially what we did, as you would even on a ward, we resent atypical pneumonia screen. You've got to think of other reasons for immunocompromisation and severe infection in a young person. We continued with his broad-spectrum antibiotics. This is his chest X-ray that night, post-intubation. So again, it was a sort of bilateral patchy consolidation, but in someone that's fit and healthy, it's pretty bad. You'll actually also see, this is further down in his mission, because he does actually have an indwelling chest drain on the right there, which was draining a pleural effusion that he developed. So it wasn't until 3 days after his admission that we were sitting on the microbiology ward round when the diagnosis became very apparent. The microbiologist mentioned that he had grown in his blood cultures a bacterium called Fusobacterium necrophorum, in which case we all sat round and went with our coffee. Oh, well, we obviously know what diagnosis is. Unfortunately, this bacterium is a commensal in the throat, but it's also pathognomonic for something called Lemierre's syndrome. So this is a very rare bacterial infection where the bacteria translocates from your oropharynx through your tonsillar bed into your internal jugular vein. During that time, you would just have a normal sore throat like you would do with another bacterial infection, viral infection, strep A, for example. But what the difference is with this particular gram-negative rod is it develops a thrombus in an internal jugular vein. So you can get up to sort of 10 days of almost recovering from your initial insult of the throat infection before your thrombus starts to throw off septic emboli. So you've got in your central vein throwing off septic emboli to pretty much any destination in your body. Commonly, lungs, which we demonstrated with this gentleman. So he has here, you can see literally it was widespread patchy opacification, consolidation, large pleural effusions which developed within days of his admission. We then were going on to an issue of how we're going to treat him. So you've got this large thrombus. So he had in his left internal jugular vein thrombus extending right down to his brachiocephalic junction. When you ultrasounded his neck, I'm afraid I don't have an image for you today, but when you ultrasounded his neck, it essentially looked completely patent, and it's just lucky that it was on the left and not the right, because I went to put in a central line on the right, and I would have been none the wiser as to why I had not aspirated blood. But when you put the Doppler flow on, there was absolutely no flow through that jugular vein. So we anticoagulated him with treatment dose dalteparin. We escalated his antibiotics to cover his gram-negative rod, this Fusobacterium necrophorum, and we added in clindamycin, which we got from looking at case reports because of the rarity of this bacterial infection. We then had continued high respiratory support and eventually was tracheostomied. We were worried about spread to his brain, so the highest mortality rate in these patients is from meningitis. So we scanned his head, and luckily it remained isolated to really chest, neck, and some evidence of infection in spleen and liver. And actually, after 5 days after he had his tracheostomy in situ, he was weaned very quickly from respiratory support, and because he had it underlying fit and healthy, he did very well. So just a brief bit about Lemierre's syndrome. So we're talking first detected by André Lemierre in 1936, pre-antibiotic era. Pretty much everyone died if you got an infection from this. Then we had a sudden surge with antibiotics. Everyone who got a sore throat got some antibiotics, so suddenly no one was presenting with it. And it's re-emerged since we were a bit stricter with what we give out. But everyone has it in their throat. Why do some people get it? Trying to explain to his mother why he's got this infection with this weird syndrome that develops in a very typical clinical pattern is hard. And as you can just see there, a total of 393 cases. I've got a review. We're literally in the hundreds worldwide. It's more common in males, more common in young males, so in your sort of second and third decade. And most commonly starts in throat, but head and neck, but throat is the common one. So this is just a very quick pattern to look how classical the syndrome is. It goes from tonsils, abscess, peritonsil abscess, thrombophlebitis in the vein, and then from there, as you can see, can spread pretty much anywhere from up to meningitis, cerebral abscesses, down to joints and causing joint infections. And just a few more complications there. Interestingly, it's also associated with Epstein-Barr virus, which our gentleman had, which is very satisfying when literally the whole picture was complete. Just a few more there. Site of metastasis. So, as we said, these are other less common ones, joint, muscle, bone. We were quite worried, hence repeated scanning. And obviously it's one of these things when you don't have common cases, you have to go based on literature, and often your clinical judgment and what you do to intervene is based on the literature rather than previous experience from us. So thank you very much, and that's it. So we just give you. So this gentleman has, as of yesterday, was in the courier.
It's not there. That's good. We'd like to be able to show you the slide, which we did have at one point, but it's not there anymore.
Anyway, go online to the courier and you can read all about it. Broccoli farmer gets severe disease or something like that.
Yep. Thank you, Kate. Right, folks. So you've heard a little bit about what we can do and some of the interesting stuff that comes through ICU and how people can arrive very, very, very sick indeed, have a whole number of problems along the way and still get out the other side alive. But one of the most difficult things your average intensivist faces is the decision whether to admit them in the first place. And one of the most difficult things we face in our job is being called to a patient's bedside and to have to make a relatively quick decision about their appropriateness for escalation of therapy to this hallowed ground that is intensive care. So I thought to try and help you understand that, you could help me a little bit. And so we're going to play with you the difficult game of should they stay in the ward or should they go to intensive care. If you do not have a voting handset from the things at the back, please pick one up, otherwise this will not work. So just while I'm explaining what we're going to be doing, please collect a handset. Basically, I've got some case vignettes for you, and after a little bit of history, I'm going to invite you to vote for what you think you would do if faced with this option. Along the way, I would like you very much to make this your own work, please. Don't confer with your colleagues, we'll get to that. And if you are prepared to vote, then also please be prepared for me to ask you why you voted the way you have, because I'd be fascinated to know what you think of these. Intensive care is not about sitting there scratching your chin when work needs done, so please be quick about your decision making. You'll have a limited window. And bear in mind what you have available to you. We would never refuse somebody admission to intensive care if they were sick enough to warrant it, but there are only a certain number of beds in which you can ventilate somebody in this hospital before you start having to look for beds further afield. So we have a finite amount of resource and we need to be careful with it. If you do recognise these as cases you've been involved in, I've changed bits of the history so they're not entirely the same. Please don't feel got at. These are being used as educational resources. And I think the only absolute with this is that there are no absolutes. Put enough intensivists in the room and they'll vote one of a number of different ways based on who they are and their own opinions about things. So this is very much about 256-bit grayscale rather than glorious black and white. Right, you're ready. I should introduce, before we start, the people to whom you will be comparing your answers, which is my panel of experts here at the front. Dr. Farden, you've already encountered. If I might introduce Drs. Sally Crofts and Dr. Ian Mellor, who are both ICU consultants, and hopefully they will provide a counterpoint to my commentary about what the expert opinion on this is. So, we're going to give you a start of a 10, hopefully quite an easy one for you. You've got a 35-year-old man here who has 2 young children. He's rolled up with a 24-hour history of fever, malaise, cough and purulent sputum. Nothing unusual there. He's got a nasty-looking consolidated chest x-ray and fairly marked hypoxia. Chugging away, respiratory rate of 42, and is ultimately, when you go to see him in the medical high dependency with his arterial lining showing that on the high-flow nasal cannula, if you've not encountered those, this is a system that can deliver high flow rates of oxygen at high concentrations, but on 80% oxygen, he's achieving that blood gas, which is fairly unpleasant, with a PO2 of only 8 when you would expect it to be significantly higher than that. This guy's struggling a bit, and you've been asked to come down and see whether or not you can help. So then, here are your options. Do you say, that's not hypoxia, this guy's fine, rubbish, I don't need to take him just now, leave him where he is? Do you say, wait a moment, I know a therapy for this, there's that thing that can put the bubble on people's head, the CPAP hood, let's use that? Are you going to be hard-nosed about it and say, well, I don't like the look of this one, just there's something funny about this? No, he's not appropriate for ICU, leave him where he is, a little bit of TLC please. Or do you say, well, you know what, we were bored down there, finally some sport, let's admit him and see what we can do? So if you would, vote now please. All right, then, we've got 63 responses. Anyone yet to vote? You've got 5 seconds still to do it while I press the forward button. Okay, 66 responses, and here we go. So, the options you have available to you. Far and away, the most likely option, then, is admit the man. Stick a tube in, let's get on with this. There were a couple of takers for the CPAP hood, 18% of you. A few of you thought this wasn't severe enough to warrant some intensive care, and a few of you weren't at all sure that this guy was appropriate for us. I'm not going to comment on that. So, 77% of you said, yes, appropriate for ICU, let's admit the man. The expert panel says?
Well, I think you're asking more than one question. Is he appropriate for ICU? I don't think anyone, well, actually, 2% of people are going to argue, but most of us would say that he is. But the question is, does he need to go now? And if you had an ICU which was rammed full, yep, and you couldn't take anyone, then I think you could try to hold on with a bit of CPAP, with the bat phone ready to call when it all goes wrong. But I think if you didn't have the beds, if you did have beds down there and they weren't full, then I would probably, for the young man who's getting worse and has got a very, very dodgy blood gas, I'd take him down. He may just need CPAP downstairs, but he's then in the right place to intubate if it comes to it. So it's not quite as straightforward as you're saying, but I would certainly refer him.
Yeah, let's see what happens. Folks?
As much as it pains me to agree with Dr. Farden, I do agree completely with Dr. Farden. This is a young, fit man who is salvageable. He's a functioning member of society. He's got his whole future ahead of him. If he needs intubation and ventilation, then he'd be in the right place. If he doesn't, then that's even better.
I don't really have anything different to say. It just, to me, it puts into mind that having separate ICUs and HDUs maybe is hopefully a thing of the 20th century. We might eventually progress into having them both in the same place, which would make the job a lot easier.
Thank you. Right, folks, so that's your start of a 10. I hope you've all got the gist of it. We're going to just branch out a little bit, okay? So, case number 2. You've got a 35-year-old man with 2 young children and a 24-hour history of infection and a familiar-looking blood gas. Okay, so we're admitting this guy, right? Except it's not quite straightforward as that, I'm afraid. Because unfortunately, this chap's in big trouble. He's got a Pancoast tumour, which has gone places, and he's got spinal and liver mets. He's had some radiotherapy to his spinal mets, but despite that, he's been in a wheelchair for the last 9 months. He's lost a significant amount of weight and a lot of muscle along the way, and is very hectic as I go to see him. He does have 2 children. They're delightful. They're sitting out in the waiting room playing with Lego. They're boys, 6 and 8 years old. His wife's heavily pregnant. She's due in about 3 months, and they know for a fact it's a girl, and they've really, really wanted a girl, and this guy wants to get to the birth. He's unfortunately moribund at this point, though, and he can't communicate and tell you what his wishes are. There's some talk in the notes that he might be amenable to some future therapy, but there's not really a huge amount of detail about that at this point. So, your choices, and this is difficult. You've got 2 children in the mix, a 3rd one on its way. This man has everything to live for. He's sick, yes, but let's give this a spin. Are you going to take a more circumspect view of it and say, well, this is a tragedy, but actually there's not a lot I can do for this man, and he's going to have to stay where he is? Do you once again reach for the CPAP hood and hope that that's going to rescue the situation? Or given the complexity of the situation, would you actually like to phone a friend? Ladies and gentlemen, if you would seize your handsets and vote now. Okay, 64 votes, 67 votes. Okay, everybody done? 69 votes. It's a good response. Let's see what you've all said. Right then. It's a very mixed bag here. I think phone a friend is absolutely on the menu here. This is clearly a complex case with a lot going on, and I think that's an entirely reasonable place to visit. Some of you have said that, yes, he's got these 2 children he's worth admitting, but you're a little bit in the minority there, I'm afraid, folks. About twice the amount have said, there's not really anything I can do for this chap, and some are still wondering about the CPAP hood. For those of you that wanted to admit the chap, would any of you care to tell everybody why it is you've chosen that option? What is it about this chap that swings your decision-making? Be brave, someone. Ian.
Oh, hang on, you need to use the microphone so we can record you forever. So.
I'm not quite so bold to say that I wouldn't phone a friend first. That should absolutely be the answer. He has a potentially reversible pathology with regards to sepsis. There are compelling reasons to give him a bash and see if we can make his sepsis better to get him to the delivery of his daughter. But I accept this is a really tragic and difficult case, and I think there's a good argument that could be made for any of those options.
Absolutely.
And definitely advice, but I think there's a good case for trying to treat his sepsis and see how he goes, and if we lose, then we lose, but if we don't get involved, then we have to be able to justify that too.
Very well. Thank you, Ian. Okay, expert panel, anything you'd like to say about things?
Shall I first? Okay. Well, it helps that it's a lung thing.
Indeed, yes.
So I can talk from at least 1 foot of expertise. Metastatic lung cancer has a terrible outcome. Whether you're old, young, male, female, have 2 children or don't, cancer doesn't care if you have children or not. And this is a terminal event for this man, which is very sad. And I think that the decision I try to make about whether the screen goes off or not, the decision I try to make about if you leave it, it might be Perth try to dial in, so right, okay. It should sort itself out. Perth. Okay, well, I've lost my thread. The decision about whether to refer this man to ICU, is it going to make a difference? Is the intervention of ICU going to make a difference to this man? He has had lung cancer for some time. He's gone beyond radical treatment, and they're offering palliative radiotherapy, which at best could offer him an extra 2 months of life, and at worst kill him. And I think this man is dying. It is a terminal phase of his disease, and it is certainly tragic. But so I wouldn't refer him to ICU. Well. I don't think it's going to make a difference. He would die on a ventilator rather than dying in relative comfort. I don't think you should put him on CPAP either. I think we are very quick to put people on CPAP because it's something we can do. But then we have to take it off. And in the same way that you have to be very careful about whether you ventilate someone, because then you have to turn the ventilator off. You have to be very careful about putting people on NIV particularly, but also the CPAP hood. Because we end up, and the chest registrars are sat there, they will nod hopefully in agreement, that we end up 3, 4, 5 days later having to make a very difficult decision of taking someone off the CPAP hood. They're absolutely fine on it, and as soon as you take it off, they're going to die. So I think it highlights a lot of very interesting things, but I think being realistic and asking the question, what will ICU do? I appreciate the concept that we should do everything we can do, but I think we should do everything we can do which is going to help.
Sure. Thank you, Tom. Yeah. Sally?
Thank you, yes. I think we have to remember there's a difference between things we can do and things that it's right to do.
Indeed.
And for this man, there is no future. And taking him to intensive care, intubating him, ventilating him, and all the inevitable sequelae that follow from that is not fair to him, it's not fair to his family, and it's not fair to his children. It's often easier if these conversations have been had weeks, even months before any end-of-life situation arises. Yep. That's a difficult thing. It's a difficult conversation to have. But if we know what's going to happen to this guy, we know he's going to die, and I think we probably have a duty to have that discussion with him.
Yep.
but I'm afraid it's sad, but there is nothing I can do.
Thank you, Sally. Ian?
I don't disagree with any of that, in as much as there's a poor man who sadly is going to die, and he's probably putting him on a ventilator is just to torture him further. And I agree with Tom about the CPAP hood. It may be time to have that realistic conversation, but the option I would have taken is phone a friend, because this is one where you have a chat with multiple specialties to sort it out, rather than just no.
Yeah.
But the answer is still no.
Thank you. So, folks, you can see that in a few details that history has changed remarkably from the first chap we encountered to the chap we're now dealing with. But even in light of these, it's never clear-cut. There is going to be a spectrum of opinion, and the expert panel is tending towards this gentleman has no future, unfortunately. It's important to accept that everybody has value, and clearly this gentleman has compelling social reasons in the background that you'd have a very, very serious look at him. And that's not diagnosis-dependent. Regardless of what's wrong with people, they all have value. But the sad reality of things is that this is about science, and the quote I've put in here is from one of my colleagues, Dr. Joss, who is very fond of saying, don't tell me about their quality of life. In many ways, it doesn't much matter. It's about physiological reserve here. Sadly, this gentleman has no physiological reserve given his disease process, and therefore the chances of us getting him out the other end of ICU are pretty much zero. We do occasionally go to see people where we're, I think, being consulted just to check that the understanding is correct, but it's clear that these people are dying in front of us, and part of our job is to recognise that and to help facilitate that in the best way possible for the patient and make as good an end as we can. But clearly, it is never ever wrong, especially if you're at all uncertain, to ask for a second opinion. And we do that as registrars to consultants to inquire, am I doing the right thing here? Would you change this? But we would also encourage it from you guys in the hospital, the rest of the hospital. If you're not sure, please get in touch with us. We'd far rather know about this and have some say in the decision making than find that you're making decisions you're not comfortable with. Let's change track slightly then. 64-year-old woman this time. Thank you, Tom. Yep.
Oh dear. Because of the VC, but bear with me. There you go.
Thank you. 64-year-old woman, previously a very heavy smoker, but gave up some years ago and certainly has marked and severe COPD. She's on long-term home oxygen therapy. But the history in front of you is that she still manages to get out to the shops. She's not been in hospital a lot recently and certainly hasn't had an exacerbation for more than a year now. But she has now presented as short of breath with purulent sputum and a clinical examination that suggests there's something going on at the bottom of the left side of her chest. Looking at her bloods, it's a little bit polycythemic. She's certainly got some infection aboard. She's taken a bit of a renal hit, and the chest X-ray agrees that she's got some consolidation there. The blood gas you have to look at carefully, but clearly this is somebody with well-established type 2 respiratory failure who is hypoxic even now. Respiratory rate of 38, she's tiring. Urine output's poor. Though her blood pressure looks okay on paper, actually that's not at all what she's used to, so that's low for her. She's in the medical high dependency on NIV with controlled oxygen therapy. So, it's a difficult one again this time. You've got a pretty sick lady here in front of you with lots going on. But do you say, well, she's got infection. This is a reversible pathology no matter what's going on in the background. It's worth a try. She still gets out of the shops, doesn't she? Let's admit her. Do you say, I'm not sure about this. The history, I need more information. Do you say, nope, I've written not for ICU, but what I really mean here is I wouldn't want to ventilate this woman. Clearly, in ICU, we are capable of providing non-invasive modes of ventilation, but I'm talking about invasive ventilation, stick a tube in and get her onto mechanical ventilation. I'm not willing to do that. Or do you try and temporise things and say, actually, you know what, I'm busy, I'll pass this over to the day team? Ladies and gentlemen, if you'd seize your handsets and vote now. Okay, 60 responses. Anybody else? 62 responses. 63. One more second. 64. That'll do us nicely. Right then, let's see what you've said. Right, and another good spread here. So nobody fancies the go away and hide option. I'm glad to hear that. Well done. Some of you are convinced that this is reversible pathology and it's worth a spin. More of you are convinced that you're not sure and you actually need some more information and to just find out a little bit more about this lady. And a fair portion of you are convinced that invasive ventilation is not the right thing to be doing here. Okay then. Those of you that have chosen not to invasively ventilate this lady, option C, would anybody like to volunteer themselves as to why that is what they've decided? I was going to say, some of you have definitely voted that. Be brave. You can't be wrong here. This is about shades of grey.
say that.
Jack, go for it. Just we'll get the microphone to you.
So my concern would be that the COPD is end stage if she's going long-term oxygen therapy and her lungs are in a bad nick. And if you ventilate them, it's just going to be really difficult to get her off a ventilator. She's already oxygen dependent at her best baseline. And I'm not sure I believe that she's getting to the shops that easily. Where are the shops? Right. You know, is she getting wheeled round to the shops? I don't know.
Yeah. I don't know. So you're not sure of the history? Yeah.
I'm not sure of the history, but I don't think that if she's got a COPD on long-term oxygen therapy, that's end of the road.
You're not impressed by this. Very well. Thank you, Jack. Expert panel. Ian, if perhaps we start with you this time and work our way backwards.
Work the way back to the chest position.
Indeed, yes. No, I'm very much saving Tom for last here. What do you think?
Feels mildly unfair. I would like a little bit more information, but I am verging on the why we're taking this lady. There is a reasonable amount of evidence out there that non-invasive ventilation is very good for COPD, and in fact the outcomes are probably better with that than they are with invasive ventilation. We are always accused of being far too pessimistic about these people, but I would struggle to take somebody on long-term oxygen therapy.
Very well. Sally, thank you, Ian.
Thank you. Yeah, I think we have to think what are appropriate ceilings of care for patients, and we need to think about critical care as what we're providing for the patient rather than the room we're providing it in. And I think for this lady, intubation and ventilation, invasive ventilation, would be an end-stage event for her. And my belief would be that non-invasive ventilation should be a ceiling of care, and it probably is not working, and this is an end-of-life event.
Thank you, Sally. And Tom?
Right. Okay, so I'm not going to disagree with any of that and then go on and disagree with it. There is an awful lot of nihilism about COPD and intensive care. And to be fair to our ICU department, I think we're probably better than many other centres I've worked at taking COPD patients. And that's not because I'm sat next to Sally and she'd hit me otherwise. But there is good evidence, mainly from America, that if you take people who've got COPD who go to ICU for whatever reason and they're matched controls, they don't do any worse. Now that's looking at all causes of going to ICU. But if you look at if the cause of going to ICU is because you've got type 2 respiratory failure, they don't do well. But not quite as badly as you'd think. The questions really here are, why is this decision not being made way, way in advance? As soon as someone goes onto long-term oxygen, we suggest that there's a decision about DNA CPR status and a ceiling of care. And we suggest they go on the palliative care register. So this decision should realistically be made way, way in advance and shouldn't really be a discussion. NIV does very well for these patients if it's done properly. And it's about making sure the patient sits up and make sure the patient's got a tight mask, there's no leak, and you ramp the pressures up, and you can do very well on it. But my comment from the last case is still very pertinent. Should she go on NIV in the first place? Is this someone who is on long-term oxygen, has no reserve critically, and is on the palliative care register, and therefore should not have been for an IV in the first place? Because again, we see people who are on an IV, they're still on an IV 5 days later, and we have to turn off the ventilator. I think from your choices, is it worth a try? I think she is worth a try as far as it goes. I think more information would be helpful. I would never say not a chance, because you need more information. She may actually be pretty sprightly, yep. And she's just got on L-top with a little bit of hypoxemia, but is actually pretty active. And I don't go to theatre, so I'm not. So I can never wait. Okay, so yeah,
that's great. So a good spread of opinion there. I think a couple of lessons perhaps to take away from that. There is no question that reversibility is important for ICU, in that if somebody presents with an irreversible pathology, what are we doing? But you have to be clear about what it is that is reversible. If the person has an underlying health problem that is so severe and irreversible, it almost doesn't matter what you add to it. You've got to seriously think about what you're trying to achieve here. Detailed history is very important, and it's impossible to take that once the sudden crash has happened. You need to have a good understanding of this patient beforehand. And something we have encountered was, does own shopping has a variety of meanings. So some people does own shopping is sprints down 6 flights of stairs, runs to the local Tesco, collects 16 kilograms of groceries and runs back up the stairs. That's fine. But it also means sits at computer, moves mouse 4 centimetres and goes click, which is actually what we were dealing with at that point. So it's very, very important to be specific in what you mean about someone's functional status, because the detail matters here. I'd like to introduce the idea that perhaps people dying is not the worst thing that can happen to them, and something that's very much in our minds is we have the technology to torture people largely indefinitely. We have to ask ourselves what we're doing. We have to ask what our objective is and what we're trying to do for good for these patients. And actually, in some situations, being strapped to a ventilator in the ICU for months on end, only to be withdrawn on because you never had a chance in the first place, is not appropriate. The hard thing is deciding what your chance is likely to be at the start. But clearly, if you're not sure, and to the registrars of anaesthetics who are sitting in the room, if you're not sure, err on the side of caution. The situations you will regret are situations where you've drawn a big red line under someone's care, not the ones you've admitted who've been withdrawn on in subsequent days when more information has become available. So, folks, I hope you've seen some of the difficulties that potentially face us at the time of referral and some of the decision-making around what we do. Thank you very much for your participation in that. That's been interesting. And I'd just like to then tab back into another presentation and continue with the last bit, which is not there. It's, sorry about this. Here. Now, I've entitled this section Survivor's Guilt, and what I'd like to talk to you about is, fine, people go to ICU, we can do incredible things and some of them get better, but what actually happens to them when they get out the far end of this magic box that is a unit on the 4th floor? The guilt here is not their guilt, they're surviving. This is my guilt because, as I hope to be able to show you a little bit, they don't necessarily all go out and flourish, and we really need to have a think about what it is we can do to support these people. Let's have a little bit of context around this then. If you look at the Scottish Intensive Care Society's audit from last year, we find that up and down the country, 46,000 people went to a critical care unit over the course of the year. Now, it's slightly difficult to tease that data apart because increasingly critical care units refer to both level 2, so what we would traditionally know as HDU, and level 3, what we would refer to as ICU beds, co-located in the same place. So it's difficult to be sure how many of these guys ended up in what we would know as ICU. But we do know that 14,500 of them went to a unit that was capable of providing invasive ventilation. And about 68% of that lot actually reached level 3 care, so that was that they were invasively vented with multi-organ failure. Of that crowd, 1/5, 20%, didn't get out of the hospital alive, so a very substantial mortality in that group. But it's not good news if you're just at the traditional HDU level either, because about 1 in 8 of those guys doesn't get out alive either. So this is a really sick population who have really high mortalities in hospital. If we look at a world stage, we find that in the United States this is substantially more again. I mean, it doesn't surprise you, it's a big country, but 800,000 patients go to what we would consider to be ITU over the course of a year. So it's a huge burden of health and expenditure on those patients. We're always obsessed about mortality, and it's not hard to see why. When so many of our patients die, clearly we are trying to do everything in our power to improve those odds for our patients. But actually, if you look at the data across the years, mortality hasn't really moved very much. About 1 in 5 have died year on year on year on year, despite all of the new advances and all of the things we've tried. And with the exception of perhaps antibiotics, very little stuff seems to really change your mortality particularly. But I would propose to you that perhaps mortality is an issue, because although 1 in 5 die, 4 in 5 do not. And therefore, what happens to them? Do we actually concentrate on those at all? We like to refer to those as ICU survivors, and you may think survivors is a slightly brutal term to describe what is going on here. So let's just look at the definition of that a little bit and why this term might be appropriate. If you consult the Oxford English Dictionary, as I have, a survivor has a variety of definitions attached to it. Firstly, a person who survives, especially a person remaining alive after an event in which others have died. Classically, think of war zones, think of battlefields, think of civilian populations caught in military action, think of people who survive terrorist attacks. They're survivors. They've endured something really quite dreadful. And it's also defined as a person who copes well with the difficulties in their life. Now, if you look at the group that survive ICU and what happens to them post-ICU and the constellation of diseases and problems they then encounter, this term is not necessarily ridiculous. Because if you compare them to, for instance, soldiers from a battlefield who have survived some incredibly horrendous battle, the diseases they go on to experience are relatively similar to that group. So is it that bad? Yes, it very well could be, and particularly in terms of the psychological consequences of having to be that poorly and the treatments that are necessary to get you through it, it's very bad for our patients. It's a difficult label, though, because I don't get up in the morning, brush my teeth and think to myself, right, I'm going to produce such horrifyingly austere conditions down in the unit that my patients are going to have to survive to get out the end of it. That's not what we come to work to do. So to say that things are so dreadful for our patients that they have this label of a survivor if they get out the end of it is difficult for the intensive care community to accept. But I think we need to get away from that because the evidence is very clear that these people do have the same diseases that survivors of other major tumultuous events have, and we need to address those. And I just wonder if that label actually helps the patients a little bit, because they go home with all of these diseases that stop them from going about their daily life, and you wonder if there's a huge amount of guilt that they've somehow done something wrong and that they shouldn't be in this situation. And I wonder if this label helps them to understand that perhaps these are diseases that are doing things to them rather than them just being weak. The Americans are very fond of classifying things, and to try and understand this problem a little bit more, you have to look at a very American term, that of the Post-ICU Care Syndrome. Now, syndromes are always difficult things to define because they're no one entity, they're a collection of things. But this one tries to describe the combination of problems that remain after critical illness. And just to be specific, these problems are not the problems that have come into ICU with in the first place. These are things that have developed in ICU and go on to trouble them for potentially a long period of time once they've been discharged. And they're very multi-system. As doctors, medical people, nursing staff, whoever, if there are other associated professionals in the room, we're very familiar with the physical aspect of this. Our patients are very weak afterwards. They can't do a lot for themselves. They often have terrible neuropathy, terrible myopathy, and have persistent organ dysfunction, usually from either respiratory or renal systems, that can potentially follow them for months or years in the time that follows. We're familiar with those. We know how to measure those. We know what to do about those. It's perhaps the other areas we're less good at tracking down. Psychologically, these people are incredibly damaged on the whole. They experience high rates of post-traumatic stress disorder, which is a really terrible thing to have if you've ever encountered someone with it. And actually, when you go looking for it, as I hope to show you in a second, the rates are really high in our patient group. Many of them go home and are incredibly anxious, can't sleep with the lights off for months, if not years afterwards. They're experiencing very high rates of depression and having significant effects on the rest of their life. To the group here, we clearly need to function at a reasonable cognitive level to work as we do. These guys almost inevitably will suffer some degree of cognitive decline as a result of them being in intensive care. And if you're a young person who relies on your brain to do your job, that's a real problem, because you're going to try to get back about your life and find you are not what you once were. You struggle to concentrate, and as a result of that, you find your work is increasingly difficult, you become increasingly socially isolated, and your entire life starts to unravel and fall apart, even though you've survived this horrendous illness that's put you in intensive care in the first place. So, there's a lot of literature starting to look at this, and I think ICU is getting better at getting away from this gross outcome of mortality as being the be-all and end-all. And I'd just like to quickly cover some of the highlights of this literature. Though as I hope to show you, this may not be the full story. Let's look first of all at physical recovery. There's been some interesting work done in Australia where they looked at approximately 200 patients with a mean age of only 57 years who'd spent anything between 5 and 6 days in an intensive care and been mechanically ventilated on average for about 80 hours. They were ultimately in hospital for just over 2 weeks, so these are not really, really lengthy stays. These are not the guys who are in the unit for a year and then try and go home. These are people who have sort of fairly typical admissions. At discharge from the hospital, they decided to find out how far they could walk in 6 minutes, the so-called 6-minute walk test, and found that on average they managed 307 metres, which for a 57-year-old is pretty poor going. These are clearly very debilitated, therefore. They then engaged in a fairly intensive programme of physiotherapy and support for the next 26 weeks, a long course of therapy, and found that even after that they were doing better, statistically so. They were managing 435 metres, but if any of us could manage 435 metres in 6 minutes, I think we would be a bit concerned about ourselves. These are clearly very, very damaged individuals just from a physical point of view. Associated with this was very poor sleep that they had to try and get on top of to improve their performance, and also poor quality of life that they observed. There's been a lot of work, predominantly from the Americans, and Johns Hopkins seems to have a particular interest in this, looking at post-traumatic stress disorder. And if you look at some of the statistical systematic reviews they've done, the incidence of this is pretty high. It's at least 20% of the patients coming out of intensive care will go on to demonstrate features commensurate with this. That's a really high number of patients, if you then imagine the damage that it causes to them. And certainly if you try to assess their health-related quality of life thereafter, unsurprisingly you find it massively affected by post-traumatic stress disease. What's interesting is that it doesn't seem to matter how sick you are or what you got into intensive care with in the first place as to whether or not you're going to develop this. really the reasons you go on to develop this are quite multifactorial and difficult to tease out. But what there's no doubt of is that if shortly after you're discharged you have lingering memories of either psychotic experiences or traumatic experiences in the intensive care, you're at very, very high risk of going on to convert to full-blown PTSD. And considering we potentially encounter these patients in wards, starting, if we ask about it, to complain of some of these symptoms, perhaps there's an opportunity to step in. It's a similar story with depression. 28-30% of our patients will go on to be significantly clinically depressed, and that has a major effect on the quality of their life thereafter. What's interesting is if you ask patients who get to 5 years how they feel about the quality of their life, only 12% of them will turn around and tell you, I am not happy with the quality of my life, I was dead. That's an interesting statistic and has been variously viewed as encouraging for the intensive care community because, hey, we must be doing something right if only 12% of them get to this lesser but still acceptable quality of life in 5 years' time. But I just wonder if that's diluted against the fact that people with a really shoddy quality of life have died in the intervening period and actually we're just not picking them up. So I wonder if there's a slight statistical fiddle on that given the damage we seem to see patients having. It's bad news if you're employed when you go to intensive care. You're slightly better off if you're a woman for some reason. By 6 months, 75% of females are back to work. But even at a year, only 65% of men manage to get back to work. Which, if you take a cross-section of us here in this room, work is important. We come to work for a reason. Not being able to get back to that would have a significant effect on our existences. And then just the cherry on top of the cake, large numbers of patients go on to experience chronic pain they did not come into intensive care with, usually in the form of some sort of neuropathy that takes a long time to get on top of. So you sit at home, physically debilitated, increasingly social isolated, dealing with difficult memories, and just to cap it all off, you're in terrible, intractable pain that you can't get rid of. It sounds fairly miserable. But I think we have to be a bit careful because the big data approach is problematic. It's problematic because it's trying to measure an indice that's very, very difficult to define, which is that of quality of life. Yes, there are scoring systems, the short-form 36 questionnaires, the ones lots of people seem to use, and yes, you can talk about quality-associated life years and produce nice graphs with those. But actually, individual people experience a real variance in their quality of life depending on who you ask and when you ask them. Your quality of life is probably different now to when it was when you were outside eating your lunch, and therefore even in a short space of time, your quality has varied somewhat. It's difficult to rate this. We also are dealing with patients that are very, very heterogeneous in the ways they come to us and the social circumstances in which they exist when they go home, and we are constantly changing what we're doing to them. So it's very, very difficult to standardise the way in which you assess this. So I just wonder if the research isn't actually the juice, which is why we've gone looking at slightly more interesting ways of gathering this data. And I think if we switch away from the quantitative data and instead go over to qualitative stuff, we get a better insight into what really happens to our patients who survive. I'm lucky in that this area, there are two of our nurses, Anne Smith and Trish Antoniewicz, who are very, very good in this field and have clearly seen a need some years ago to establish some sort of support network for patients who survive ICU and get it back out in the community. Periodically, there are groups that meet that are ICU survivors, some are old, some new, and try to lend each other a little bit of moral support, a little bit of advice, and they get an opportunity to ask about all these funny dreams and experiences they've been having and put in touch with the right services. Several of this group have very kindly shared their experiences as a narrative. I planned to show you video footage, but unfortunately I haven't been able to get the technology to work, so you'll have to forgive me, I'm going to do sound bites instead. But certainly, if you're anything like me, I found this very, very sobering information indeed. First chap says, oh dear, I was hoping that would play a little bit better than it has. I can't get sound. Not to worry, well. I have this dream, they said. I keep having it all the time. I'm in the Pentland Hills, walking the hills. That's strange. I've never been there before, but I know that's where I am. The police are after me. They keep getting closer. Every time they spot me, there is this noise. And the sound I was going to play you is the sound of one of our ventilators alarming. And every time that sound happens, the ground shakes. I can't get away from them. This poor chap had this persistent nightmare that turned into a daydream that he's still having to this time, having gotten out of ICU. And I think, looking at the detail, probably this is him coughing with the ventilator going off by his head to a high airway pressure alarm, and the shaking is us performing endotracheal suctioning and him kind of coughing on that, which makes him feel like the ground is shaking. But this persecutory police after me, not sure where I am, I'm in an unfamiliar place that I've never been before, with this strange noise that when we played him the sound, his face fell and he said, oh no, that's exactly the noise, I hate that sound. It's a really sort of traumatic memory, and clearly this chap is developing PTSD because he's able to quote these memories back at you. I trained as an engineer. I was brilliant with my hands. I liked to fix motorbikes. When I got home, I had horrendous pain in my arms and hands, and it wouldn't go away. 5 years on, I still have it. The medicines only take the edge off. That first week at home, I was so happy to be alive, and then I went to the loo. Suddenly, I found I couldn't wipe my own arse. I was too weak. That was too much. I cried like a baby. I had to get my 73-year-old mother to help. There are some things your wife shouldn't have to do. Again, a terrible, terrible experience for this chap who was delighted to have survived. This guy had flu. He was delighted to have survived his dreadful experience and yet found that things were not as they had been when he got home. And this horrible realisation that he was almost back to being a child all over again hit him really, really hard. A younger guy this time saying, getting back to work was hard. My work were really good about it. I got phased return, lots of help, but it's not the same. I can't concentrate anymore. I keep forgetting what I'm doing. I used to be a manager. I've had to step down. It was too much for me, and it wasn't fair on the rest of my team. This is another flu who has clearly recognised that a deficit exists, and yes, he is still at work, but it's not necessarily in the capacity which he once enjoyed, and this has had an effect upon him. And then another person, I've thought about killing myself. I keep thinking about it. I've even found myself writing letters to my wife just in case. I would never do it, though. It wouldn't be fair. She's already been through so much. So things are so difficult for this guy, having survived this tumultuous event, that he's seriously giving thought to whether or not he wants to be here anymore. And they're dreadful experiences, and they're really hard-hitting, because they show us that we think we've been successful, they've gotten home, fantastic, but actually there's more to it than that. For my own peace of mind, I wanted to ask this group whether or not, knowing what they know now, they would actually still be up for going to intensive care when they'd first presented, and reassuringly all said, yes, I'm glad you took me, I'm glad to still be here, despite all the things that are happening to me. But once again, caveat auditor, this is a group who are self-selecting, who have turned up at a support meeting and are alive and are willing to talk to me. Perhaps that's because they're upbeat about their existences and have gotten on as best they can with things. So in light of this, and in the last 5 minutes, I want to talk about what we can do to help. We've already covered a little bit about why it's important to try and admit people who have a meaningful prospect of getting back to a good level of function to ICU, and that if they're at the end of their lives and at the end of long illnesses, perhaps invasive ventilation is not the place we should be visiting. But I think it's more than that, because we can do that, but we're never going to be sure what's happening at the far end of it. And we have to try and support our patients who get out alive, the 4 in 5 who are going to get out of ICU as survivors. And really, I think it boils down to communication more than anything else. It's important that we communicate with you, the wards to which we are discharging, because you need to understand what these patients have gone through in terms of their medical therapy and the risks that they now face in terms of developing other pathology, some of which you will look for because that's the area that you handle. And, for instance, if they've had a pneumonia, they're coming to a respiratory ward, that's clearly your field of expertise. But I think there is certainly a communication and indeed an education issue around looking for other things like PTSD and psychological stuff that starts to rear its head back in the ward. We also, as a group, need to get better, both from ICU and also from the wards, at communicating with staff back in primary care. Because actually, though GPs perhaps know that their patients have gone to ICU, they have very, very little understanding of what it is has happened to them there. So clearly, if someone's gone to ICU, had a tracheostomy, renal failure that needed some dialysis, been floridly delirious and taken a long time to get out, they're things the GP needs to know about, but unfortunately rarely discovers. This is going to take a number of strands here. We are going to look at ways in which we can communicate better with primary care. But clearly, those of you writing discharge scripts in the wards, please don't just cover your own area. There is more to the story than just what's happened when they get back to the ward. The other strand of this is at a national level, we're trying to push GPs to be able to code for some of this. So if you see different GPs every time you go to the GP, at least your notes tell them some of the things that have happened to you, and hopefully will identify you as having the post-intensive care syndrome and all of the horrible things that entails. If you are seeing these patients post-ICU, really it's perhaps fairer to think of them more like the elderly population, in that their needs are complex and they need plugged into physiotherapy, occupational therapy, even full-blown rehabilitation to try and improve their outcome. And they're not the young population that you would expect to see who just bounce back from their illness and go home. These are people who are going to have long-term needs and may ultimately require some degree of care at home. We need to give them access to that and support to be able to access it. Equally, education isn't just about us, it's also about trying to help the people around them that care about them to understand what's wrong with them, so that they don't find that in the coming year their partner leaves them because she doesn't understand why they can't just go back to work, or he doesn't understand why she can't just go back to work. There's clearly an education need and a support need for the people left behind as well. And nationally, this has been identified, and there are a few pieces of work looking at this, probably most primarily the profile study being done down in Edinburgh by Tim Walsh and Naz Lone, which is looking at why people come back into hospital in short order after they've got out of an admission involving critical care, but along the way has found some really interesting data about how people manage once they go home and some of the factors which really upset their life and how we can try and improve that. And it's starting a fairly interesting conversation between lots of different specialists and lots of different areas within the NHS about how we can support them better. So with 2 minutes to go, the bottom line from this whole talk. Katie, I hope, has shown you very nicely that ICU can do amazing things. We see some incredible patients with some really interesting pathology who will go on to do really, really well if we treat them properly. And we have lots of technology and lots of learning that helps us to do that. But it's important to choose the patient that is appropriate for that. Sometimes that's a really sticky area, decision-making around who to take to ICU and ventilate and who to perhaps leave behind or identify as dying is hard. And I hope we've given you a bit of a flavour of why that's not an easy decision for us to come and make inside of a couple of minutes when we've been summoned to a patient's bedside, and why we need your help to be able to do that in terms of early discussions and as much information as you can give us. And I hope we've subsequently shown you that, yes, they might get out of ICU, but actually survival is not enough for these patients. It's about quality and about trying to improve the way in which they go home and exist. And we need to do more about this. We as an ICU need to do more. We as a hospital need to do more. And we as a country need to do more to try and improve their outcomes at home. And on that note, ladies and gentlemen, I thank you very much indeed for the opportunity to speak. Thank you very much indeed for your attention and participation, and invite any questions you might have.